Bismillahirrahmanirrahim. Today we will demonstrate a case of chronic total occlusion CTO of CIRC OM. And this case was very tough and very difficult, and I think it follows about a lot of tips and tricks, and we will try to demonstrate it exactly here. This case I named it under a title of When the Way is Not Straight, So Follows the Nature. Clinical presentation. This male patient, 63 years old, dyslipidemic hypertensive, known to be ischemic heart disease and non-diabetic. He is complaining from chest pain and dyspnea on exertion, Canadian Cardiovascular Society Class 2, since more than 3 months. He had an history of PCI to LAD and LCX-OM within about 17 months, and he had 2 drug-eluting stents, one in LAD and one in the LCX-OM. Currently, ECG showing sinus rhythm, steady wave changes in posterior leads, echo demonstrating good function, ejection fraction about 62%, but there is a segmental motion abnormality at posterior lateral wall hypokinesia. There was a failed trial to recanalize CTO in stent restenosis of OM about 2 weeks ago. And now this is the recent ongoing trial to recanalize that CTO-OM1. This is a coronary angio and the PCI, as we see here. Look at that video, and we will know exactly how it will be difficult to recanalize that in stent restenosis, because as we see here in this video, how the wire, curvy wire in different projections and in different planes, and as all we know from the physics of the wiring, when you have a lot of bends, especially if bends about 90 degree angles with different blends of the 3D construction, if we suppose it, how this will lose all of your pushability of the wire. So at that time, the failed trial that was done 2 weeks before that intervention, the problem was that if any wire trying to hit the proximal cap of the in-stent restenosis of that OM, the wires buckles in the so straight right angled left main to LED. Every wire trying to hitting the proximal cap of the OM, they will be buckled in the LED. This is because that you're having a tough CTO in a curvy LCX and OM, and also the LED angulation with the left main is a right angle. So there is a straight way between LED and LCX. And also this way is so wide. So you're losing the contralateral support of the vessels to push or to help the pushability of the wires to penetrate the proximal cap. So that was the main issue or the main reason why the first trial was failed. It was actually with me. But I learned from this failed trial that I need to abolish this unsuitable physics of this anatomy. So I was mandated and obligated to bring a curved steerable tip microcatheter like venture microcatheter to abolish these unsuitable conditions of this anatomy. And as we see here, this is the angio and how is the venture microcatheter entering the left main, and then I curved it to pass this right angle of the left main with the circ, and then I tried to pass the wire. This wire was I think this wire was PT2MS, and as you see here from this video, that the microcatheter is sliding over the wire, and this wire just when it hits the proximal cap, it bends and buckles in front of this proximal cap, and that give you the sense that this proximal cap is tough proximal cap, very stiff, not a soft or or moderate a stiff proximal cap. It's a very hard proximal cap. So at that time, I left the microcatheter here and was drawing this PT2MS, and I start to bring a wire with properties of hydrophilicity and a stiff wire. So my choice was a Pilot 200 inside the venture and trying to navigate the proximal cap of this OM in-stent restenosis. And as you see here, how the wire behaves, it is just entering and penetrating the proximal cap, and I'm still inside the borders of the frame of the stent. I tried different projections and also withdraw and approximating the tip of the microcatheter to support. The wire advanced a little bit, but the system started to buckle again. Another projection. So at that time, I start to realize that I need a more stiff wire. So I am escalating from Pilot 200 to a Gaia third, because at that time and with my sense, I feel that I need to do a well-controlled micro-dissecting passage inside this well-delineated stent frame. So my choice was the Gaia third, and also I put this Gaia inside the venture microcatheter, and as you see here from this frame, how I do this well-controlled micro dissection side by side with a little push and a little penetration, and I start to gain a lot of land, as you see here. I think I passed the distal part of the stent. But after that, I tried several times to advance the microcatheter to follow the wire, but actually it doesn't pass, or didn't pass. So I withdraw the wire and bring the PT2MS, start to follow the path that this PT2 or the Gaia third produced by this well-controlled micro dissection, and actually the PT2MS managed to pass. I tried to push the microcatheter, but as you see here, it doesn't go, and unfortunately the system, all of the system are buckled and passed away. So at that time I realized that I need a more support, so I have a different kinds of anchoring, but I start first with just passing a wire in the LCX proper to the distal LCX, and I tried to take the Pilot 200 again to navigate through this in-stent restenosis. And as you see here, at that time I start to bring a balloon 1.0 by 10 millimeter, just to support the wire, and once I have an advancement inside the in-stent restenosis, lesion, I start to inflate the balloon just to create a more pathway. I change the wire again to the Gaia third, and I put the balloon over it, and as you see here, several trials again and again. I take another projections, try to see if I'm inside the pathway or not. Actually, I was in need for a more anchoring, so I passed a wire B2MS just abluminal, just to do an anchor wire support through a substrate's position. And I managed by that way to advance the wire and over it a balloon. Then I retract the P22MS wire, and the balloon managed to cross the in-stent stenosis, and I passed finally the distal cap, and at that cine, as you see, the one 1.0 balloon tried to navigate the in-stent lesions, and I escalating the balloon with about 2.0 by 15 millimeter, and I start to inflate. And as you see here, finally the architecture of the artery was clear, but there was a distal dissection distal to the stent, and I start to put a stent distal, and as you see, finally this is the final result, a very big OM with distal branching. So the incidence in chronic total occlusion intervention tortuous coronary arteries are a significant anatomically challenge present in approximately 29% to 30% of cases. Tortuosity complicates every phase of the procedure, from initial wiring to the final delivery of stents. Impact on procedure success: lower success rates. The technical success rates drop significantly from 88% to in a non-tortuous vessels to about 82% in tortuous ones. Increased complexity: tortuous lesions often have higher GCTO scores, averaging about 2 point versus 2 for non-tortuous, and are frequently associated with heavily calcification. Shift in strategy: tortuosity often necessitates switching from an antegrade to a retrograde approach. Common technical challenges and navigation issues: extreme bends, angles more than 70 to 90 hinder the delivery of microcasters, balloons, and stents. Physiological ambiguity: tortuosity can mimic stenosis or lower FFR-IFR reading due to the concertina effect, vessel kinking caused by the stiffness of the guide wire. Complication risks: there is a higher incidence of vessel perforation, 6% versus 4.3%, and major adverse cardiovascular events made during these procedures. Key tools and techniques to overcome tortuous anatomy: operators technically or typically utilize guide support techniques using guide caster extensions, guide liners, or side branch anchoring or distal anchoring techniques to improve stability. Specialized wires: selecting polymer jacketed wires for their lubricity and durability in sharp bends. Supportive microcasters devices like the Corsair are favored for their flexibility and the kink resistance. Body wires: placing a second stiff wire to straighten the vessels and facilitates equipment delivery. In navigating tortuous anatomy during CTO intervention, guide wire selection follows a structured escalation algorithm based on the need for trackability versus penetration. The first initial strategy is often the lubricus tracking. Operators typically start with low tip load polymer jacket wires. These are designed to slide along the path of the least resistance in tortuous segments while minimizing the risk of vessel injury. Preferred wires: Fuller XTR 0.6 gram tip load and Sion Black 0.8 gram or Whisper MS. Technique uses small 1 millimeter curve at 45 degree to facilitate steerability through bends. The second, intermediate escalation controlled steering. If the soft wire fails to track or buckle, operators switch to wires that balance flexibility versus with 1-1 torque control to actively navigate the curves. Preferred wires, Gara Ferris or Gara Next One. These features a composite core scientific that translates hard rotation precisely to the wire tip. Intermediate polymer wires like Pilot 200 is often used for longer, more complex tortuous segments where trackability is still prioritized. The third, high resistant navigation penetration for tortuous vessels that are also heavily calcified or have blunt proximal cap. Stiffer tapered wires are used to drill or penetrate. Preferred wires, the guy second or third for steerable penetration, or Confianza Pro 12 for high force puncture. Fourth, retrograde for retrograde and collateral navigation. In extreme cases, the retrograde approach is used, requiring ultra flex specialty wires to navigate fragile collateral channels. Typical collaterals like Sion and Sion Black, and epicardial collateral SO3 0.3 gram tip load is specifically designed for highly tortuous small vessel navigations to avoid tamponade. So to conclude our case, a combination of tortuosity and CTO increases the difficulty of percutaneous coronary intervention. It becomes challenging to deliver guide wires, balloons, and stents to the target lesion. In confronting a case of CTO and tortuous anatomy, one must be ready with all available anchor tools. Dedicated microcasters like dual lumen, curved tip, or steerable tip must be in one's toolbox, specifically in such kind of tortuous anatomy. And thank you.